Yeah, thank you very much for the invitation. It's a great pleasure to be here and to see so many people interested in cartilage. And of course, it's now a difficult task for me to tell you something about cartilage, since you already heard how difficult it is. But I think it is worth investing some time also in the cartilage, and not only in the alignment and the stability and all the surrounding factors. So we're talking about autografts, osteochondral grafts. Is it? But as Elisabetta has shown, don't forget all the other techniques, because they're all important, they all have different indications, and they all have different size limitations. So, in the Oates technique, I come from Munich and spent a couple of years with Professor Imhoff, and we had a vast experience to the Oates procedure in different kind of areas in the knee, but also in the humeral head. We did some mega Oates and the talus. But recently we performed a little less than in the beginning of the 2000s. The surgical technique, I think it's pretty much straightforward. You need some dedicated instruments to take the cylinder. It has to be press fit to get a good hold. You take the cylinders from the proximal lateral or the medial trochlea. So it's a size limitation of how many cylinders you can take, and then you can bring them press fit. Some special at the patella is that sometimes the bone is very hard and it's difficult to harvest it with the cylinder, so sometimes you have to over drill it with a drill and then use the Oates instruments. And the second thing is you have to be very precise at which angle you harvest your cylinder. This gives you the additional advantage to three-dimensionally reconstruct the area where you want to be. So the advantage is it's a one-step surgery, it's fast, it's cheap, and it's the only cartilage regenerative method that really gives you autologous hyaline cartilage. It has a good bony integration, therefore it's pretty fast, stable, and it has good long-term outcome. Here you see a 10-year after an Oates procedure, and it's a perfectly reconstructed joint surface, in this case on the medial femoral condyle. But for the patella you need an open exposure, it's limited in the size, and you have a little bit of donor side mobility, like we looked at 200 cases of Imhoff's study, but only small one. I think this is the ideal case. A young lady with an osteochondral defect, so you have to treat both. You take it out, put in a new plug, and basically that's done. You can also do it with a little bit larger defects, like in this mosaicplasty, but I think 3 cylinders in this technique is the upper limit, otherwise it's difficult to get a stable anchorage of these cylinders. Is it a perfect fit? You see how nicely the patella fist is reconstructed using the Oates cylinders. I think that's good, but that's another problem, and that's probably why the cartilage treatment on the patella is more difficult, because you see the size difference here nicely. You see the small cartilage coverage of the cylinder and the big cartilage of the patella. The surface, of course, is perfectly congruent, but we don't know if this might be one reason why the outcomes of the patella are a little bit worse in cartilage therapy than on the medial femoral condyle. But, of course, look at everything else as well. We like to do lots of tibial tuberosity distalization, because patella alta has emerged more and more as a risk factor for cartilage damage and later on for osteoarthritis. So please treat the whole joint. If you look at the evidence, there's a systematic review from 2014 about OCTs. It's better than microfracturing, but of course it's for the smaller defects. The long-term results at a mean follow-up of 10 years for defects up to 2 square centimeter was 72% success rate. Negative predictors were older age, previous surgeries, and bigger defect sizes, of course. And if you compare all the different treatment methods, cartilage in the knee, we see that there's not so much difference between the ones. Elisabetta also showed a nice study. There's maybe a little bit worse outcome between osteochondral allografts, but the next speaker will talk about this. But this is the major advantage of an OCT, the return to sports, because you get hyaline cartilage. it's nicely integrated, and you have 92% return to sports at a mean time of 5.2 months. And this is double the time as for the other methods as shown by Critch. And also, if you look at the Tegner score, after 5 years, all treatments go a little bit down, but the oats after 5 years is still the best regarding the Tegner score. So this is a big advantage. So in Germany, with our size limitations, we have recommendations of our working group when to do what: bone marrow stimulation, augmented with a matrix, ACI for the bigger one, osteochondral transplantation for the smaller one, and minced cartilage is still trying to find its role, and we have to elevate it. So to conclude, it's a simple, cheap and effective procedure, but it's only for small lesions. You have to do good meticulous surgical technique, have other cartilage restoration procedures available for larger lesions, unloading of patellar cartilage defects, tibial tuberosity transfer, and also treat associated lesions. And of course, I want you all invite to the ESCA Congress 2024 in Milan. And with that, many thanks